Fancy. All right. I want to thank everybody out there for joining us tonight. This is the Thoracic Surgery Residents Association Congenital Career Development webinar, and it's sponsored by our friends at Atricure. And we have this whole webinar series set up for early career development. We had our first one last month on robotic minimally invasive cardiac surgery. And tonight we have a couple people here to discuss congenital cardiac surgery, particularly early career development. So I'd like to welcome our two panelists. We have Dr. Elizabeth Stevens. She's an assistant professor of surgery at the Mayo Clinic, former president of this organization. And we also have Dr. Damien LaPar, who is coming to us from the frozen tundra of Houston tonight. He just recently moved down there as an associate professor of cardiac surgery there at the University of Texas, Houston. So thank you guys for both joining us. I'll let you guys each introduce yourself as we start off here. But just want to start off with you, Dr. Stevens. Maybe tell us a little bit about kind of how you developed an interest in congenital heart surgery, how that kind of came to fruition over time, and kind of this early interest in the field, how you dealt with that.
Yeah, well, thanks for having me. It's a pleasure to try to help others who are interested in this field. So I was MD PhD at Baylor Rice, and in our embryology class, this was fall of my first year, they had a guest speaker who was Dr. Chuck Frazier, who used to be head of Texas Children's, and I just was captivated. I went up to him afterwards, and I had never met a surgeon before, didn't really ever think I would be a surgeon. Yeah, it just went from there. I did my PhD in valve bioengineering, and did a postdoc at Stanford, and then I did Columbia I6, and then Chicago Laurie Children's Congenital Fellowship, and then I joined Mayo as an attending last December. So.
Good. And how about you, Dr. LaPar? Same question.
Yeah, so a similar story to Elizabeth. I too my interest in congenital was a little bit organic in that, I don't have a scar on my chest. I'm not a congenital heart surgery patient myself. So I actually went into medical school thinking I was going to be a geriatric primary care physician. And then through various experiences and mentorship and early exposure in medical school, I started developing interest in cardiac surgery, and then I really became fascinated when I started hanging out with the pediatric surgeons. And then we just kind of grew from there. As I gained more experience and was around more and more of the surgery and around more and more of the surgeons, I just felt like it was probably the thing that inspired me the most. And so I just sought out more and more opportunities. I did my training at University of Virginia, did my general surgery training and my adult cardiac surgery training. I spent 2 years in the lab there. And during that time, I really had some great mentorship, and I think that's going to be a consistent theme probably throughout our talk tonight, is about the importance of that specific, not just in your careers, but specifically related to congenital heart surgery. And then from there, I went up and did my congenital training in Boston Children's. And then I took my first job at Columbia right about the time during Elizabeth's, actually her chief resident year there. And then I was on faculty there for just almost 4 years. Then got recruited to come down to the University of Texas, where I just started down here as the director of neonatal cardiac surgery, and I'm the associate chief of the department here at the Children's Hospital down here. And I just started here at the beginning of the year. So it's been an interesting and exciting journey process, and I'm happy to share kind of my insights through several different layers of the pursuit. I'm eager to hear what some of our attendees have to ask us, because it's a big moving target, congenital is. And I think everybody who's attending now, they're doing the best thing they can, which is to get in as much insight as they can, as early as they can.
Yeah. Great. And just to add on to that, please, if any of our listeners have any questions, please use the Q&A function. I'm monitoring that, and we'll inject the questions when they're appropriate. You both already touched on what I was going to ask next. And that's, it seems like early exposure and, particularly mentorship are kind of the key thing in getting into the specialty. You guys both got involved very early. What kind of advice do you have for people who kind of come to it later? Maybe they came through a traditional general surgery route and they're just starting and they've had that first congenital rotation and they decide later on that they want to do it. How would you go? What would you advise those folks?
I mean, I think that the same principles apply. You know, just because my interests may have developed earlier than another person's doesn't mean that you can't be successful or you're kind of behind. I think the same kind of networking, getting to know as many people as possible, finding mentors at your institution and other institutions are all key. You want to find out as much as you can about the specialty. And in terms of mentorship, I have had mentors for like various aspects. So when I was on adult cardiac, I had a particular mentor who was actually the VAD surgeon, and he was just very perfectionistic, very OCD, but he made, and a lot of other people didn't want to scrub with him, but he made me so much better. And he was kind of like, you know, he made me technically a lot better, and he clearly was not congenital. But I think you want to be looking for mentors in various aspects. It might even be someone who, you know, is a mentor for a clinical or OR portion of your career, and then you have other mentors who are more for like your academic pursuits or other aspects. So if you're interested in during general surgery training and things like that, I think again, the same sorts of things apply. You want to immerse yourself and find out as much as you can. Like any specialty, there are always things that you maybe didn't want to have as part of your specialty. I remember I was kind of interested in vascular, but then you had to deal with diabetic feet, and I was like, well, I hate that. But you know, in congenital, there are some really great highs, and when it goes great, it's really, really great. But you also need to be aware and be willing to take the risk of some really deep lows. And so, in any case, as anyone making an educated decision, you want to learn as much as you can before, try to know as much as you can before you make that decision.
Yeah, I would add on to that. I mean, the field of congenital is incredibly seductive. I don't honestly know any person that I've met who's gone into any aspect of medicine at baseline who doesn't come into the operating room and watch a congenital heart operation and think that it's awesome, because it is. I think you have to balance that when you come in and you start to watch something that's really cool and awesome. And I think you have to balance that with the realities of what the field are, which is it's really hard. It takes a lot of dedication, dedication from yourself, dedication from mentors, dedication from your family, dedication from all of that. And, you know, the first piece of advice that I got when I went and started talking with one of our senior surgeons in my training about going to congenital was like, why would you ever want to do that? That's what everybody gets asked. How are you going to do that? That's the next question that everybody asks you. And most people don't have a good answer for that. And so that's where you have to develop almost a mentality, I think, if you're going to be successful in pursuing congenital, that you're willing to do whatever it is that you have to do in terms of training and taking a job and all of that to be successful. And it's not, you essentially have to find it within yourself and find the support within your families that you're going to adapt in whatever way that you need to for the field. And I don't say all this to be negative or anything. I just want to be very honest with people. And I try to be very honest with people when I'm counseling about this field, because it is an incredibly seductive field to go and watch and be around, and you see these things. But as Elizabeth said, it is a field that it's just all highs and all lows. There's very little middle ground in what you do. Like rarely do you go to the hospital and come out and like, yeah, that was just a normal day. Like things either are going really well or they're not going well at all. And I think that you have to be prepared for that, and you have to ask yourself if that's kind of the lifestyle that you want to have. And so once you've checked all of those boxes, and if you've decided, I see David Blitzer's on the call as I sat and talked with him, once you're willing to put your head to a wall and just plow through whatever it is and whatever obstructions that you may come across in your pursuit, and you're willing to do that, and you get accepted that and that's what you're going to do, well, then it's great, because then you've made that commitment, you made that decision. So now it's just a matter of figuring out how to make that happen. And that's where you need to have a lot of grit, but you have to have a lot of guidance. And so whether or not you start that process as a second-year medical student, or as a second-year general surgery resident, or as a first-year thoracic surgery resident, I think it's more about the character of who that person is and what it is that they're willing to do and figure it out. Everybody's usually smart at this point in the game, and everybody's usually pretty capable, because most people that pursue it have gone through pretty good training and they figured out how to be good residents and all that. But beyond all of that, it really comes down to, I think, a true visceral commitment to the field and what you want to do. Because as most people say, everybody always, you'll hear it over and over, the hardest part in this is getting that first job. I'd actually take that a little bit further, because it's really not about getting that first job. There are plenty of first jobs out there, but a lot of them suck. So what you want to do is you want to find a job, and the right first job with the right first mentor, because there isn't anybody, I don't care who it is, I don't care who stands up at the podium, I don't care who's sitting around at the table at the mixers or whatever and tells you, there isn't a good congenital heart surgeon out there who honestly look you in the eye and tell you, oh, I came out of training and I was ready to do anything and everything. You have to be patient. And Elizabeth and I have talked a lot about this in your early careers, is you have to learn to be patient, and you have to learn to continue to accept the fact that you're going to adapt as a surgeon in the first several years. And I'm still in that phase of trying to be patient and learning what I can, and then trying to figure out what it is that I know, and also figuring out, that I know what I don't know, and working through that process. But I don't think it really matters too much when. Obviously, like anything else in life, if you can figure it out early, you can kind of plot your course earlier. But it's really more, I think, about finding that commitment within yourself and within your family and all that to do what it is that it takes to really make this successful.
And just to build off of what Damien said, I mean, all of that is so true. I think one of the things that as trainees, you can get a little bit of a false sense of the congenital world. And I remember when I met with Dr. Fraser very early on, and he said, yes, cream always rises to the top, you'll be fine, you'll be great. But there are people, it's a very hard field, and there are people all over the country who are kind of wandering around looking for jobs who haven't made it in whatever sense. And so when you're in training, you are exposed to people who have made it in congenital, like they're at an academic institution, they clearly have made it far enough that they're, at a big center and doing relatively well. So you don't see, as Damien said, all these first jobs that are like ECMO procurement jobs or like help the call schedule jobs. You're seeing a different, a select part of the congenital world.
That's a good point. To kind of pull off of that and what Dr. LaPar just mentioned, once you make the decision that, this is really for you, this is what you want to do, what are some concrete steps that the potential applicant for congenital heart surgery should be taking during their training to make themselves competitive for that match? It's, it's a very competitive, it's a very unique match. So Dr. Stevens, let's start with you, and what can we do right now and then take concrete steps to make ourselves ready for that process?
I think a few things. One, I would say first, on each of your rotations, whether you're on thoracic, adult, for the general surgery folks, if you're on vascular, you want to learn the most you can out of each of those rotations, because each of those skills will build into your career. So I think it can be, some people are just so tunnel focused that they're not gaining as much as they can. The second thing I would say is to give yourself some grace that, so we had looked at this a while back, so many people in particular who enter the integrated program think they want to do congenital and don't end up ultimately doing that. And that's okay. You don't have to, you can change your mind, and there are many reasons to change your mind. So I think that's, I always, when I talk to students or what have you, it's great to have an interest, but along the way, you want to be completely invested in each rotation that you're in, check those out, learn as much as you can. As far as the congenital match, so I started, I think it was about 3 or so years before my match, 3.5 years. And I would arrange to meet with the program directors at national meetings. I know that that's not really happening right now. and try to meet them and see what their program was like. That can be very awkward, and sometimes that's best done through your mentor. So Dr. Bosch was my mentor at Columbia. Obviously Dr. Fraser was my mentor from earlier, so he would also ask around. Congenital match is very challenging. Probably the majority of spots are often already arranged for, even though it is technically a match. And so it can be hard because not that many spots are actually open. Not that that really can change, that you can change that, but you can get a sense of if a spot, and sometimes they'll specifically tell you, like I remember Michigan specifically told me, we already have someone slotted for that. Boston was pretty clear. Stanford was pretty clear on about who they had lined up. So talking to people early and having your mentors talk to people is great. As always, internal candidates have an upper hand for the most part if they're well liked at that institution, but you can't do anything about that. So that, be it as it may, I think those are some of the key things.
Yeah, I would add, first and foremost, you have to focus on your training that you're doing at the time, like Elizabeth said. You have to be a good surgeon, bottom line, to be a congenital heart surgeon. And most congenital fellowships, your surgical experience, your actual tangible, hands-on, you're on the right side of the table actually operating as a surgeon is usually fairly limited during your training. Some places say they do more than others and so forth, but the reality is it's usually not like it was at most adult training programs in terms of how much you actually operate. And so if you come into that kind of an environment where something is as technically demanding as congenital heart surgery as a practice is, and you don't have those basic tools that you're going to bring to the table, then when you do get those opportunities, you don't usually perform that well, and then you end up usually, getting sidelined and you're on the bench. And then congenital heart surgeons, like every other arrogant surgical specialty out there, tend to then start labeling you as being either good or bad, or cut it or not cut it. So I think you really want to focus on the basics to begin with. You have to be a good surgeon. You have to learn how to operate. You have to learn how to make your way through an operation, not just focus on how you're going to hold a needle driver and pass a needle through a tissue. That's basic stuff. That's hopefully what you're getting in your first kind of junior years of training. By the time that you're finishing your adult cardiac training, if you're preparing for anything, whether it's a job or a fellowship in congenital, hopefully at that stage, you're focusing on how to set up and actually run an operation as a surgeon. And you need to be able to bring those tools to your fellowship, because if you don't have those, then your fellowship experience is not going to be all that great. And then when you're out there trying to find your first job, people are going to start asking them, you're going to kind of get labeled as like, well, they were okay. Well, they were okay as a fellow in congenital pretty much means like, yeah, you probably shouldn't hire them. So you don't want that. So at a very minimal baseline, you want to focus on your training while you're in training. Don't turn into one of these folks that's like so focused on being a congenital heart surgeon that like, I don't need to scrub on that cabbage again, or I don't need to scrub on whatever it is, because it's all going to come back and you're all going to need to do that. Secondly, depending on where you are and when you make your decisions, research is great, okay, for a couple of reasons. One, because it helps build your CV, and most of the places that you're going to go to already have very accomplished, well-trained cardiac fellows that are applying, and so anything that you can do to kind of help distinguish yourself within the herd is going to be helpful, and that's where research comes in. But more importantly, like Elizabeth was saying, research that gets you to meetings and gets you to the podium in a non-COVID environment where you have face-to-face time with people is critical, because that's where you're going to start to meet these people. You're going to start to develop relationships. That means when you go to the meetings, you want to be focused on developing those relationships. If you go and stand in the back of the congenital room, never get to meet anybody, or more importantly, you don't have a mentor or somebody who's going to help facilitate and sponsor you in that environment to get you to know those people and start having those conversations, you're not going to move forward as much as you would like. So that brings me to the final thing, which is you got to find somebody. We've all had somebody who's going to help you. And that doesn't have to be at your own institution. Okay, Elizabeth was talking about being at Columbia and relying on Chuck Frazier a lot and getting mentorship from him. I was at UVA, and Emil Basha, my former partner, gave me my first job, was like my biggest mentor. And like, we didn't even like hardly know each other. We just got to know each other at meetings, and he became a tremendous mentor and advocate for me. And so it doesn't really matter. It doesn't have to necessarily be the surgeon at your program that's going to be that person. It just needs to be somebody. And sometimes that somebody needs to be somebody like Elizabeth or me, somebody who's close enough to you that understands what it is that you're doing, that's not too far away from the game that it is that you're trying to play, that you can help strategize with. And I'm not going to speak for Elizabeth, but I already know her answer. But I'm happy to always, help counsel folks in that, because we've all had to have that. We've all had to have those mentors who are going to help guide us.
Good. So we'll move on. Already got a question about the next topic, but the next topic is the first job. You both alluded to it already, so we'll just keep going around the circle. How do you find said first job, and how do you make sure it's not the kind of more dead-end procurement ECMO job and a good mentorship environment? What are you guys looking for in that? How did you find that?
It's one of the scariest steps, and you're just so afraid because people tell you can go through all this training and do very well and not have a job or not have a sustainable job. Sometimes the job finds you, which is how it happened for a number of the jobs I was looking at. The vast majority of these are word of mouth and are either not posted or posted later. So much of this is networking, like Damien said, being on committees with people who know you, being at the podium, being at meetings and discussing things, letting people know when you're graduating. And many of the congenital programs will have an idea of when a space will open, whether it's a person retiring or increased volume or things like that. So I actually was not, I was scheduled to graduate after 2 years, and some, for a number of reasons, I started looking at some jobs were looking at me. I guess that was a year before I was due to graduate, or maybe a little more than that. So the Dr. Draney just met with me at STS in one of those years and tried to convince me to come here. And so that's how that happened. I think a lot of it, again, comes the actual job, and whether someone approaches you comes through mentorship. Dr. Basha, I remember, was involved, even though I was no longer at Columbia. He was involved, and my other mentor, Dr. Backer from Chicago, was very involved. As far as what to look for, I think this is very hard to judge. In particular, you want to be under someone who is invested in your career. They're already invested in their own career, but you need someone who they want you to get to be good. And that can be really hard to tell. I remember I was looking at one job, and he had said all the right things about, I want you to be successful, I'll scrub with you with hard cases. And then you're always looking for collateral information, calling different people, calling people who've left that institution for a variety of reasons to try to understand, what may have happened. And you're trying to assess whether they're really invested in you. And so I think Damien's already alluded to this. That mentorship in the first few years is so important, because not making it in the first job is really hard to come back from. And so much of that is the senior person you're with. And on a number of levels. One, they give you the cases that you should be doing. 2, they're helping you at appropriate times. 3, they're protecting you when something might go wrong, whether it's your fault or not your fault. And 4, just giving you guidance on the clinical and non-clinical elements. The leap from fellowship to an attending is much more than I ever thought. And it's at so many levels. It's not just the clinical, the OR, it's managing people, being a leader. There's so many things, the psychological stress, the emotional stress. It's a whole new ball game. And that being able to make that leap successfully is very reliant on who you're with. And it's not that if you're at an institution like with multiple surgeons per se, it's not that you necessarily need to have like one person who's your mentor. Like even here, even though Joe's my mentor and is really, you know, who I rely on the most, there are a few things that another surgeon is kind of like my more senior person that I run things off of. So you don't need to be completely reliant on one person. But you do, again, to get from a new attending to a successful new attending a few years in, you're very reliant on that type of apprenticeship model. And Damien and I have talked ad nauseum about that and how to navigate that. I think one of the things that you look for, which is very reassuring, is if you're with a person who has done this for someone else, which actually Joe hasn't specifically done. So that was something that, you know, I was trusting that he's, you know, mentored many people, but not in kind of my specific role. But if you can join someone who's familiar with that process, that's extremely helpful. Because I think one of the things, I'm trying to finish writing like a little editorial about my first year, but one of the things that I didn't really realize is when I finished fellowship, I felt pretty comfortable with certain things. And it's almost like a false sense of comfort. You're incredibly reliant on a system around you, your senior attending with you. And when you get into a whole new environment, you don't have a world-class surgeon as your assistant, you realize, oh, maybe I wasn't as independent and capable as I thought, you know. So I think that can be a little bit of a shock, but getting through that, you're relying on your senior mentor.
Yeah, I would agree with everything that Elizabeth, all the sentiments, everything that she said. I think in terms of advice, I would start out by saying that you need to, I think, understand and wrap your mind around the fact that every interaction that you're going to have from this moment on with any person in the congenital field, you need to view that as a potential job interview. At every meeting, I don't care if you're a second year resident or you're like a second year congenital fellow looking for a job. Every potential interaction that you have with a congenital heart surgeon around the country is a potential interview, because many of these people, and I've come to learn this more and more in the past few years as I've kind of matured a little bit into this role. Many of these people are recruiting 7 years, 8 years out in the future. They know what the needs of their programs are. And they're meeting people who they think 8 years from now might be somebody they want to hire. And so it's interesting because then you get to know those people, and like 7 or 8 years later, all of a sudden they're talking with you about a job, and you're thinking, wow, that was serendipitous. Well, no, actually it was planned. And that was kind of what they were planning to do. And so I think that if you have that mentality every time you go to a meeting, or every time you're involved in a committee, or anytime you have any interaction, it's only going to help you. I mean, I was looking at one job and essentially interviewing with them for like 4 years before I finished. I decided not to take that job, but that's how long that process really was. When you're selecting things to look for in that first job, like Elizabeth said, you have to really find that commitment from somebody. So how do I think you do that? Well, I think you just have to be honest. Ask them point blank. And sometimes it's a little bit, it seems, you know, I don't know, intimidating to do that. It seems a little precocious, maybe a little assuming, but it's too vital of an opportunity that I think if you don't assert yourself and tell them what you're looking for and what you need and get an honest assessment of what it is that they're going to provide, I think that's where people sometimes fall down. And almost every person that I've talked to who has, for a lack of a better phrase, failed to launch into this field, it's usually kind of boiled down to that when I start asking them. I say, well, did you actually ask them point blank, how many cases am I going to do? How are you going to help me? When are you going to be available? How are we going to do this? How many cases are you going to let me do? How many of your cases are you going to let me do? Anytime somebody starts mentioning research in our field as your first thing that they want you to focus on and as an early career attending, to me, that should be at least a potential warning for what it is that their intentions are for you. Because most people who really, really, really honestly care about mentoring you as an early career and as a first job congenital heart surgeon, most of them are going to tell you, you need to focus on operating. You need to focus on learning how to do this. You need to focus on figuring out how to actually do the cases and do the job. The research will come. A lot of people going into this field have done a lot of research, and it's been their key to success so far. But that all, the rubber hits the road in this field very, very, very quickly. And all the research in the world isn't going to save you from a bad outcome on a TET in the world of congenital heart surgery. And that is just a bottom line, like hard to swallow fact. Nobody cares that you had X publication or doing whatever if you can't actually do the job that they're having you, or if they ask you if you can do something and you tell them that you can and then you can't, that's even worse. So you have to have a mentor who is going to, and you have to have somebody who's hiring you who wants to make sure that you're going to be successful first and foremost as a surgeon. Academics will come. I think I don't know what Elizabeth's experience has been in that, but I know her mentor fairly well, and I know that he is the type of person that at the end of the day believes that he's going to make sure that you can operate before you're doing other things. Of course, everybody wants you to do academic. Everybody wants you to run a lab and bring in $5 million in research funding. That sounds great, but that all means nothing if you can't actually do the cases. So you need to find that very, very, very early. And I think you need to be very honest about what your expectations are from the very beginning.
Just to continue on that, we'll reverse the order. Dr. LaPar, staying with you, what are some of the biggest challenges that you faced during your first year out?
Well, first year out, I think every congenital heart surgeon, and I know Elizabeth and I have talked a lot about this, is you come out and you assume that everybody else assumes that you should be able to do X, Y, and Z. And you can insert whatever it is into X, Y, and Z because that's going to change so much. But there's this feeling that like, oh my God, I got to prove myself as a surgeon, so I need to be able to get independent as doing an arterial switch or doing all the Norwoods or doing this or doing whatever. Well, it turns out most of the time, you're not going to come out and nobody is going to refer you a Norwood. And just, usually they're sending that to the senior surgeon who actually has seen one and actually done, more than 2 in their career. And so, but they will refer you the 7th time redo pacemaker that nobody wants to do. And you're spent the last year scrubbing on all the uninterrupted aortic arches and truncus and weird things that you might see because you think that that's what you actually need to do as a congenital heart surgeon. You haven't focused on doing a pacemaker, and then you're trying to figure out how to do the pacemaker, and that just seems kind of embarrassing. So I think what you need to first and foremost understand when you come out is that you're not ready, and you need to be patient. And you need to work through that process, and hopefully you have a trusted relationship with your mentor who's going to bring you through that process. And then you need to learn to be patient again, and it will come. It is a process. I mean, my Emil Bosch, we keep talking about him because he was a big influence for both Elizabeth and myself, but he told me it took him 10 years in this field before he actually felt like he knew what he was doing. 10 years, and he's a good surgeon. He had good training. It just takes a long time. And so I think when I heard that, it helped me to kind of take a deep breath and realize like, okay, you need to be a little bit more patient. If you come out assuming, and like we all come out with this like entitlement of like, well, I should be doing every neonate that comes through the door. Why? Because you feel this sense of like urgency to get up and prove yourself in that way. The reality is, I would argue you need to kind of switch your mindset and say, I should be doing every single ASD, every single PDA, every single VSD, every single pulmonary valve replacement, every single redo, every single thing, and start getting all of these tools and put them in your toolbox so that you can do it. Because turns out that if you can learn to do an arch, and you can learn how to do an RV to PA conduit exchange, and you can learn how to do an atrial septectomy, it's just a few more stitches, and then you kind of put that all together, and that's called a Norwood. Now the baby's smaller, and technically, you got to figure that out. But if you don't have those tools, and you don't know how to set up an operation, and you don't know how to do those aspects of things, it's very difficult to actually put together a major operation like that. So I think you just need to learn to be, in your first year to 2 years to 3 years to 4 years, it's a process. You just need to learn that it's okay to say, I'm going to be patient. I'm not going to set the expectations too awful high for myself. I'm going to work with my attending, I work with my mentor and come up with a plan. And then I would say, write it down. Every person that I've talked to about early career development, and I still do it to this day, I tell them to write down a 3-year plan. A 3-year plan that includes everything from clinical to research to professional development to personal development to everything. And be very, very specific about what it is under each title, how many cases you want to do, what type of cases you want to focus on, things like that, because it gives you something not only to come back to on your own, but it gives you something to meet with your mentor about, to say, hey, look, I had said, and we had initially talked at the beginning of the year that I was going to do 250 cases focusing on stat 1 through stat 3 cases this year, in my first year, to become proficient. And turns out I only did 68 of them. And they say, yeah, you did a good job. So now we're going to do this, but it gives you something to come back to. So I think having a plan and writing it down, I think is really helpful. And it also helps you to come back to it about every 3 months and look how out of balance kind of that portfolio is, because maybe you've been focusing so much on this over here that you haven't done anything over here, and it helps you to kind of recalibrate all of that.
Yeah, there's just so much to talk about in the first year. It's like, I don't even know where to start. So as Damien and I talked at length about going into my first year, and I wrote out 1, 3, and 5 year plans. I regularly meet with Joe to go over my progress. We go through clinical education and research shields. I agree that research focus early should kind of be avoided. I'm in a little bit of a different situation that we have so many databases here, and I think I have 14 students or something working under me on various projects. But I would say, again, as Damien had said earlier, the most important thing is that you need to be able to operate. And whether you like it or not, when you finish fellowship, you might think that you can be able to, you can operate, but you're not, you aren't. And that needs to be really a focus for the first year. I think there's so many aspects to the first year, and I think it depends on where you end up. If you're in a larger group where you're like the junior most on the totem pole, that's going to look very different than my year, which is a little different, where I was brought in kind of as the face of peds and was expected to be a leader of the ICU and cardiology. And that's a lot of responsibility for a first year attending, to kind of assume that level of leadership when you're just figuring out how to be an attending. I think I alluded to this, but the emotional, psychological stress it's real, and it's a lot. And I remember Joe said, early on, like, to not schedule 2 cases a day, that as a new attending, it's too, unless it's like, I don't know, something ASD and something else, but it's just a lot. And I think that's something that I hadn't heard people talk about. And the other thing that'll happen during your first year is you're going to have some bad outcomes. And, during fellowship or during residency, it hurts. I mean, you took care of the patient. I'm sure you owned the patient, just like we all did when we went through training. But when you're the attending and you're meeting with that family, you can't describe it until you go through it. And that has been something that you kind of have to grow up. Not that many, I talked to a number of people, like how you deal with that. I think each person has to deal with that differently, but it can be really hard, because you have another case the next day and you're going to meet with another family and say, I'm taking your baby or child to the OR to fix XYZ. And you just went through whatever bad thing that happened, whether it's your fault or not your fault. It could have been, completely non-surgical. So that process is, I guess, I've talked a lot also to Dr. Backer about it. He's like, well, that's the natural process as maturing as a surgeon, but people just don't really talk about it. As far as the progressions of cases, I think Damien was absolutely right. And I've kind of followed his leads on, what you want to be independent on and work towards that. May is a little different in the case mixes is skewed, and so it's not like we have a gazillion VSDs coming in, and we don't have as even a case mix as some of the places in the city. So part of what I do is a lot of more complex redo things that that's different. But I think setting those types of goals for yourself and then meeting regularly with your mentor about how you're accomplishing that is extremely important. And then just learning as much as you can from each and every case. I took a lot of notes when I was at Columbia and in Chicago, and same thing today. I have my notebook, and I write all my notes beforehand. I write notes after, things I want to remember. I videotape cases and review them and things like that. You want to just keep working to get better. And one of those things that Damien alluded to is the ability to conduct a operation and be the leader in the OR. And so that's something that, like in Congenital, you also grow into. Yes, you were in some ways conducting the operation as a fellow, but being able to redirect the staff when you change your plans or get the whole staff through an emergency. That's also something that you're learning to do as a new attending and figuring out.
Yeah, the other thing I would add is that, you come through training, and most folks have been at centers like Elizabeth was saying, where you work with these world-class surgeons, and you kind of watch like, oh, how does so-and-so manage their day, and how are they so capable, and how are they so successful at being, a teacher, and being on an administrative role, and then being and maybe doing research, and then doing 2 operations in a day, and doing all of these things and putting it all together by 6 p.m. And you kind of develop this idea that, okay, I'm going to model so-and-so, and that's how I'm going to do it because that's how I saw them do it. And then the cold hard reality is when you come out, you have a very limited bandwidth as an early attending. Like, you got a case, and most people sit and think about that case, and you're preparing for that case, and your mind is attached to what it is that you're going to do in that case. And that occupies a lot of your time. The preparation, the amount of mental bandwidth that you have to do all of the other things that you see other people do is just not there. And then you're also slower than they are, because maybe you've done 1 or 2 of these by the time that you get to doing that. And they've done, 200, right? So like a senior congenital heart surgeon, they don't really think twice about going to the OR and doing a Norwood and then switching and then going to do a Ross in like the room that's staggering next door, because they've been in that situation so many times that they have a routine. They know how they're going to set things up. They know how to do it. They don't have to think about the case other than like when they walk in and adjust their headlight and step up to the table. Whereas when you're in your first few years, like there's all of that other preparation that goes into it to try and figure out how to do the case. And so you have to be ready and willing to accept that aspect of it and figure out how you're going to ask to deal with everything else. And I think that's where you have to, again, I come back to being patient and trying to figure out exactly how it is that you're going to be successful. Because, the quickest way that people fail in this career I really think that as I've come a little bit further down the road in this field, it really is not about your first job. It really ends up being about what your first 3 to 5 years look like. Because a lot of people come out, and a lot of people have high expectations for people, and they go in and they do this, and then you see these people that never really materialize as surgeons, and maybe they don't get recruited into another job, or maybe they just kind of hang around the same place not doing anything. And other people come in and kind of take over and grow into that program. And so it's really about trying to figure out how to put all of those pieces together. And it's hard. And I think that if you can surround yourself with the right environment, with the right support, and create a network of people around you that are going to help you be successful, that's how you're going to do it. Very few people are going to figure out how to do this all alone on their own.
Another thing that I was thinking about that I think is worth mentioning is being very aware how you portray yourself and how others perceive you. In that Joe and I were talking about this the other day of navigating an early career. You need to develop credibility where you are. And so Damien and I had talked about this a while ago. being realistic about what you can't do or shouldn't do. Like we had last week, we had this emergency in a 2.19 kilo neonate who had acute MR in the setting of a cath lab injury. And they wanted me to repair the mitral. I should not be repairing a mitral on a 2.19 kilo baby on PGE who's a preemie without my senior person there. That's completely inappropriate. And I think one of the things that we kind of alluded to earlier, people make very early judgments about you. That's cardiology, that's ICU, and that's other surgeons. And whether it's fair or unfair. So I hadn't even used their infant pan, and I had a switch come up that Joe wanted me to do. And Joe had never even seen the way I do a switch, which is kind of a combination of background for me. And it was stressful. I was using pickups that didn't hold baby tissue, which was really annoying for a whole case. The baby did very well, and incredibly blessed for that. All of a sudden, cardiology think I'm like the next Cooley. Of course, I'm not next then Cooley or like DeBakey or whatever. I did a switch and it went well, and it was my first case there. But from that also comes sort of these expectations. Like we had this very high risk neonate that came, I guess about a month ago now, that they wanted me to do. And they were like, oh, but you've had these great results for X, Y, and Z. That does not mean that I can do or should be doing this high risk neonate. So I think being realistic with your cardiologists and your ICU colleagues and stuff, they honestly don't really understand some of the things about why, like the other case that they were asked, they thought I should do has a 15% mortality nationally. That's higher than a Norwood. Like just because I can do a switch or do some of these other things does not mean I should be doing this case that I've never seen or scrubbed, let alone done. So I guess that was a little bit of a combination of things, but I think it's very important that you establish credibility. You know what you can do and what you can't do. They will start to trust you. If you start to be a little arrogant or like, oh, I think I can pull this off, and it doesn't go well, you've lost their trust. So establishing that credibility, being very aware, unfortunately, there's a lot of eyes on you, especially early on, and they will make those snap judgments. And then as always for any of these cases, I was talking to other people. I was like, I have this baby coming in, has XYZ condition. Like, I think that's something that's above my head right now. Sure enough, yes, you're right, Elizabeth. This is how you should handle it. So, going to those advisors who include Dr. Basha and Dr. Becker, you keep your mentors, stay in touch. I text Dr. Becker all the time. You want to, they're so valuable. So stay in touch with them.
Yeah, I think you have to, establishing your relationship early is really, really critical. And the easiest way to destroy that is for people to think one of two things. Either you're arrogant or you're unsafe. If you're unsafe, it's a problem. If you're arrogant, you better be really, 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 really good. Which most people, you don't have that luxury of being able to pull off true arrogance in your early career in congenital, because the field is just too sobering. If you get your reputation of having bad judgment or being unsafe or being arrogant and you hurt babies, it's over before you even begin, because that's what people are going to talk about. Thing that I didn't quite realize until I started going through this period of being recruited into a second job is how many cardiologists know each other around the country in different areas. Every single cardiologist that I came down, before I even met with them, had already talked with like 5 cardiologists that I knew in New York. And they all wanted to know one thing, like, is he safe? Is he going to take care of my patients? Is he a good judgment? They didn't care about anything else. They didn't care about, is he a nice guy? Like, what, anything. All they cared about is like, is he trustworthy? And I think that if you don't establish that early and you don't establish good judgment, it's going to be death. And I've worked with some partners who, they flirt with that. They flirt with arrogance and judgment calls. And it's something that you just don't have the luxury of getting away with. At some point, I think in your career, after you've done like several thousand operations and you're a world-known expert in something, you get to the point where people start blaming the baby for a bad outcome and not you, because they assume that you know, it wasn't the baby, it wasn't Dr. So-and-so's fault. That baby must have just had a really bad heart. But you're not going to get that stage for a long period of time. So I don't think that you can try and model that behavior that you may see somebody who gets away with something, or at a big institution where maybe they get away with it as an institution, simply because they have a reputation for many years. You're not going to have that luxury.
We had a question come in through the chat about adult congenital as a kind of a developing practice area, and where you guys see that fitting in the early career. Dr. Stephen?
I might know who that's from. So adult congenital, it's Mayo has the highest volume of that in the country, and there will be increasing need, no doubt, for adult congenital. It takes a unique set of skills because you need to understand the inside of the heart, the three-dimensionality, these previous repairs, some of them are not done anymore. And you also need to be skilled at dealing with more adult issues, comorbidities, multi-time re-ops, hazardous reentry, aortic surgery, stuff like that. So it takes a unique skill set. Unfortunately, there isn't like a direct path for that. And most jobs at institutions will have, one of the surgeons or maybe one or two of the surgeons who have a relatively smaller part of their practice, the adult congenital. And that can vary with different institutions. Some of the bigger institutions, that can be more of someone's practice than less. I think there will be more transcatheter interventions for some of these adult congenital issues, but there will always be a need for someone who's very gifted with open adult congenital. And unfortunately, I think that will be, there's always the debate, is it going to be at the Children's Hospital, adult hospital, with that, and that's worked out at different institutions in different manners. I do think that people who should be doing those operations should be ACGME congenitally trained people who have that understanding of the heart and the anomalies, who are then taking care of adults with congenital heart disease.
Yeah, I would 100% agree with that. I mean, I think especially early in your career too, adult congenital is an emerging field because we're starting to see more and more, adults that have gone through the process of being operated on when they're younger. Now they've survived to the point where they're showing up and needing something else done. And everybody usually, it seems like people are like, oh, the neonate needs to go to the senior guy or the senior person. And so, oh, well, that person's, I don't know, 25 or 30 years old. Well, let's just have, let's have Damien do that. Let's have Elizabeth do that. Because that's easy. I mean, adult congenital is just tough. I mean, these cases are hard, I think. I mean, I don't know. I went in because I like operating on little babies, and at the end of some of these adult cases, I'm tired, my hands hurt, I've been pulling on things that I didn't really want to spend my career pulling on, and they're just slogs and multi-readed cases, and the patients usually are sick, and the cases are hard. It's not like the redo that you did in adult cardiac surgery. It's like the redo that your adult cardiac surgeon was like stressing out about doing, and they've been doing it for 20 years, and now that's just like that's like Monday morning for you in the adult congenital world. And so they're tough cases, and I don't think that they should be taken lightly. I think when you do, you usually end up in trouble. All of a sudden, that coronary that normally is not there while in this patient is there, and now you're in trouble. Not that I know that from personal experience, but I'm just saying that those are the things that make a adult congenital heart surgeon much more equipped at dealing with, because they've seen there and they know how these anatomic variants are compared to an adult acquired heart surgeon who deals with normal, structurally normal hearts that have gone wrong. So I don't think that it's something that, people should just kind of take lightly when they do. I think it's a great field, and people, that want to spend their careers doing it are going to have a huge, niche to go into. And there are some centers like Elizabeth's, for example, that just have a tremendous need and volume for that. So you can have a very successful career if you like doing that.
Well, we're approaching the 8 o'clock hour. I want to thank you both again for giving us your time tonight. That was an excellent discussion. I'll go to both of you for any closing remarks or things that we haven't talked about that we should have or whatnot. We'll start with you, Dr. LaPar.
Yeah, I would just say that congenital is like the coolest thing ever. It really is, and I highly encourage everybody on this forum to consider going into it. We focused a lot tonight on how hard things are and what the road is, and it's difficult and challenging and all of that. But I mean, what did JFK say? We don't go to the moon because it's easy. We go because it's hard. Well, that's the kind of people that congenital heart surgeons are. They're people that are inspired to go and push beyond the barriers and do the things that other people don't want to do. And when you do that, it is incredibly rewarding. And so I think that everybody, just by attending tonight, has probably demonstrated to themselves that they have a real interest. And I think that you need to just find somebody who can help you to help cultivate that, but then to help promote you along the way. And like I told you earlier, I'm happy to meet with anybody myself to do that. We've all needed that, and I look forward to chatting with anybody if they want to talk some more.
Yeah, I would just echo what Damien said. There are such high mountaintops, so really deep valleys, but I can't imagine doing anything else. It's a real privilege to take a child of someone to the OR and fix their heart. I mean, it's should always make you nervous. I remember Dr. Fraser, I said that to me. If you're not nervous before a case, something's wrong, because you're about to operate on some son or daughter's heart. And so and I echo Damien's. I know I've talked to a number of the people on this call, and I'm happy to mentor further, talk further. It is a long road, it's a hard road, but I think it's a privilege. And I love what I do. It's even in the OR today, we were saying if it was easy, everyone would do it, but we do it because it's hard, but also because it's a calling. So anyway, I hope this was helpful for people. Happy to talk further for anyone.
Thanks a lot, guys, and nice having both of the former TSRA presidents on the line tonight. So.
Yes, Damien was the TSRA president before me. He got me in the lineup. So.
All right. Have a good night, guys. Thanks,
All
everyone.
right. Take care.
Thanks, everybody. Have a great night.
All right. Bye.